Alexa Curtis. I'll open my slide set up in a minute. Let me just give this a go. I'm going to share my screen. Correct, Dr. Rivas?
Yes, ma'am.
Okay.
Let me know if there's any problems.
Okay, let me give it a try and see if I can go what view works here. So let's now let me see if I can go into slide view without screwing things up so much so that I can't.
Excellent.
Yeah. Okay, I'm good, I think. So hello, welcome to, well, thanks for hanging in there this day. I don't know if you're trying to move everybody here. Let's get you down below. This has been a great day so far. I certainly have enjoyed it, and I appreciate you all staying to the afternoon. So this breakout session is a discussion of medications for opioid use disorder, as well as harm reduction approaches. So those are huge topics, and we could certainly touch on them meaningfully. And this is supposed to be a think tank. This is not a fishbowl. So my expectation is that you will be full participants in this fish tank, and please do share your wisdom with me and the other participants. So given that, can we just do really brief introductions? Who's in the room? What your name, your position, such as I'm Alexa Curtis, I'm a nurse practitioner, I practice at Granite Wellness. Can we start?
Yeah.
Anyone?
I can go.
Okay.
My name is Brandon. I'm an assistant professor for the Addiction Studies program at Diablo Valley College. I'm working on my dissertation right now for my doctorate in public health, influence of DEA X waivers on practitioners prescribing buprenorphine. So I am highly interested in this chat right here.
Fabulous, and feel free to connect with me later so congratulations on pursuing your PhD in public health, and I'm happy to work with you at any time. Just shoot me an email.
Oh, that'd be great. Thank you.
My name is Katie Wood. I'm a program manager at a federally qualified health center called Family Health Centers of San Diego. I oversee our medication-assisted treatment program, our behavioral health integration teams, and one of our intensive outpatient drug Medi-Cal county-funded programs as well.
Fabulous. Please do chime in with your wisdom of program management. Family health centers, is that what it's called in San Diego? Family.
Yes.
Yeah, I'm a San Diegan, born and raised, still have a place in Imperial Beach. So
nice.
Speaking my language, went to University of San Diego. All right, next.
Hi, good afternoon. This is Ana Contreras. I'm from Imperial County. I'm a behavioral health manager for the Adolescent Substance Use Disorder Treatment and Prevention Program.
Fabulous. I just feel like I would like to spend the rest of the day in the next couple of days with all of you guys. Myself, I'm an adolescent health person, and we were one of the recipients of the Your Youth Opioid Response Grants. Did you have one as well?
Yes, absolutely. We just ended. I was going to share that. I was really excited. We requested an extension as a result of the COVID. It really impacted our adolescent program significantly, and still is. So we speak the same language, working with adolescent, with youth. And so we just ended our grant December 31st, and we applied for the second round. So we're waiting, we're pending response.
Fingers crossed for you, fingers crossed for us.
Thank you.
We certainly all need the money, and that's such important work. And again, likewise, shoot me an email. I'm the one in charge of getting the youth in, and we are really struggling getting the youth in, and I can share some of those stories. So.
Thank you so much, and I will be in contact with you.
Who else do we have in this esteemed group?
I'll go ahead and go. My name is Michelle. I am currently pursuing my master's at University of San Diego. So yay. And I am getting my master's in school counseling, and I have received the HRSA grant, where I've been focusing more with students with substance dependence issues.
Fabulous. Another youth and SUD person and San Diegan. Next.
Hi, good afternoon. My name is Mireya Reynoso. I'm also in SUD in Imperial County. I just started as a clinician, so I'm learning a lot, and I really like it.
Fabulous. What type of clinician are you?
Well, it's at SUD, so I'm learning a lot. I come from the mental health side, so I'm kind of transitioning into what is everything that's substance use.
Excellent. Excellent. Well, welcome to the game. Welcome to the team. Who else do we have? Have we covered everybody? I only have 5.
Hi, my name is Melissa Wagner. I am currently a master's student at Sacramento State, and I'm doing my internship at the Counseling Center of Diagnostic Services in Sacramento at Sac State. And I just have a passion with working with youth, and so I thought this would be a great addition of knowledge.
Fabulous.
How you guys doing? I'm Sal Joshant. I'm a father of family San Joaquin. I'm doing my practicum right now. I'm intern, SUD intern. I graduated from UOP, University of Pacific in Stockton, California. And I've been, man, trying to get over this little hump that I've been over with. It's just because it's a little mountain. And I finally got over it. You know what I mean? And I'm finally achieving my goals. Being incarcerated in and out of prison over 23 years. You know what I mean? I had the similar story as Chris. You know what I mean? I understand what the childhood is. I was born in Afghanistan, lived in Germany 5 years, been here since '85 with my family, and false pride took me down. And my self-esteem was broken inside. I couldn't speak the truth, and I couldn't talk to nobody. But and I want to bring a change to Stockton, California with Fathers and Family San Joaquin, and hopefully just reinforce a lot of things that's going on, especially for the broken justice system. Thank you guys.
Wow, thank you, Saul. Congratulations, bravo. We appreciate the work that you're doing.
Thank you.
Can't see my whole galley, so I don't know who else is out there.
Good afternoon. I'm Argelia Garcia, Special Associate for Initiative Struggle nonprofit organization here in the east side of LA. We are actually a grantee of the Seattle Health Foundation. So we started this process 2 years ago to do outreach and education to the community, specifically with youth and families that advocate and organize in the east side. And so we were happy to receive any information, and we're currently in the implementation process. So creating workshops and surveys and really messaging around reducing stigma and providing connections to services.
Excellent, thank you. Anyone else?
Hi, I'll go ahead.
Please.
Hi, I'm Eugenia. I am a recent grad, a 2020 grad of Cal State San Bernardino in the school counseling and guidance program. And I'm recently an associate, so I'm hoping to start my practice. And
Excellent.
So I've been learning a lot today. I really appreciate this workshop and all the work that you're doing.
Excellent. Thanks for being here, and thanks for sharing your wisdom.
Hi, my name is Ton, and I am a student at Sacramento State doing the Marriage, Couples, Families program. I am also a nurse at Sutter Hospital in the ICU, and I'm also a military nurse.
Wow.
And I am a student. I'm here to learn, and I strive for better understanding to help anybody that I come into contact in any of the fields that I may work in the future.
Wonderful. Welcome. Very cool combination. RN, I don't know if you're RN or LVN, but nurse and counselor. Very nice. Anyone else?
Hello, my name is Fernanda Gonzalez, and I'm a substance use counselor at the Imperial County Behavioral Health Services. I'm working right now with adolescents, and I have experience working with adults as well.
Wonderful.
Hi, I'll go. My name is Anna. My name is Anna de la Torre. I'm also from Imperial County, and I currently work with SUD adolescents, but I'll actually be starting a new position where we work with the local hospitals to navigate patients with any SUD issues. So I'm excited for that and excited to learn.
Fabulous.
Hi, I'm Jacqueline. I'm a student at Cal State Long Beach. I'm getting my master's in public health. And I also work as a research assistant under Dr. Bavarian. We're studying prescription stimulant misuse and diversion among college students.
Great, super interesting, important topic. And as you know, I imagine there's, and other people who have applied for a youth opioid response grant, the second round, there's a real focus as well as the state opioid response, not just the youth. There's a real focus now looking at stimulant use disorder. Who else? Okay. I can't see my panel. So if you haven't spoken up, feel free to interrupt me and speak up. So again, I'm Alexa Curtis, and I am a nurse practitioner at Granite Wellness. I'm both a family nurse practitioner and a psychiatric mental health nurse practitioner. My other world, I'm the assistant dean for graduate nursing at the University of San Francisco. I used to teach at Sacramento State. I taught there from, I want to say 95 to 2013 in the School of Nursing. So I'm also a Proud Hornet. I have multiple allegiances. So this is my grant team from UCSF. It's the ADOPT program. And what we're really doing is working on providing support for our learners, NPs and MDs, to make sure that they have the competencies needed to treat opioid use disorder when they graduate, and then working with our clinical preceptors and our community partners as well. And we are funded by SAMHSA. And there's the email or the web address. There's a ton of resources on our ADOPT site. So in particular, like I wrote one on epidemiology, I wrote one on harm reduction. Can't remember what else is up there that I wrote, but if you go under resources, you'll find a bunch of interesting resources if it's helpful for you in your work and your study. And please do, again, always feel free to contact me or any member of our team. I'm not going to go through a lot of the basics. I want us to talk, but sometimes people aren't clear on language and I'm going to move you all down again, have questions about why we use certain words over others. I don't get hot and bothered about it. We all know what we're talking about. We're talking about opioids. And when we are talking about opioids as clinicians, now remember, I am a clinician as well as an educator. And my own PhD was in community health systems from UCSF. So I am very much a community health focused nurse and a psychiatric mental health nurse. So when we talk about substance use disorders, we're always talking about making this DSM-5 diagnosis. That's our driver for the diagnosis always, whether it's opioid use disorder or another type of substance use disorder. But I really like to reinforce when I'm talking to people, because especially when I'm talking to people in the community, it doesn't matter, particularly what opioid I'm talking about, we treat them the same. So one of the things that I like to really reinforce with people, and those of you who've worked in the field understand that treatment works. And that recovery happens. And we know that substance use disorders are considered, in the chronic disease model, and that we understand that part of recovery are relapses. I like to differentiate between lapse and relapse with my patients. There are lapses, and that does not necessarily need to build into a full relapse. But I think the best kept secret in all of this is that this is a great place to work, because as people who are working in the field know, we see people get better. And I want to emphasize, I'm super happy to hear that Jacqueline's working in the area of stimulant use disorder. We've had such this hyper focus on opioid use disorder for really good reason, obviously, recently, but let's not lose sight of all of the other substance use disorders that are significantly impacting our communities. There's over 20 million people in the United States with a substance use disorder. So we need to continue to consider this full spectrum. And this includes adults and youth. And then methamphetamine use disorder I put here, but you could slash it to stimulant use disorder, such as the stimulants that we use to treat for ADHD. What we want to emphasize with people is that there are medications to treat opioid use disorder. There's medications to treat alcohol use disorder. We now have fabulous life-saving treatments to treat opioid use disorder. We don't really have anything for methamphetamine use disorder at this point in time, although there's a lot of trials going on. And then reinforcing again that that best practices is to combine medication with behavioral therapies. Now, if you know the literature, you know the POAT study, opioid addiction treatment. I can't remember exactly what it stands for, but it's a seminal study that really showed that the outcomes were not significantly different between people who got medications for opioid use disorder and people who got medications for opioid use disorder and behavioral therapies. So this is a little hard for some of us to digest, given that we understand the importance of behavioral therapies, but really my interpretation of that study, and it's POATS, if you want to look it up, just write POATS and you'll find it. The take home for me and a lot of people is just that we don't withhold treatment for opioid use disorder if people can't get into behavioral therapies. And I'm going to stop in just in a little bit once we get to adolescents, but just again, because we have such a mixed group, just being really clear on what the medications that we have for opioid use disorder, methadone, which is a full agonist, buprenorphine, which is a partial agonist. So the Suboxone that, is primarily what we're using out in the it is what we're using out in the clinic and in the community, and naltrexone, which is an opioid antagonist, which blocks opioids onto the receptors. But really what we're focused on now is Suboxone, the buprenorphine. And the reason we're really focused on the buprenorphine is it's a partial agonist. So what we know is that it's very, very, very difficult to dose it to the level where we would have an overdose death. So that's what makes buprenorphine more safe than a full opioid.
I was going to leave.
Oh, let's see. Someone's on the phone.
Got him muted. Question, Dr. Curtis, in the chat. Let me know if you would want it now.
Oh, please, anytime, interrupt me.
Absolutely. So from Brandon, how beneficial is injectable naltrexone and oral oh my gosh, I'm having a day.
Bupropion or Wellbutrin combined for methamphetamine use disorder. It's showing that's new.
Yeah, so yes, that is on the, so let's stop and go back. In terms of, I'm sorry, who asked the question again?
Me, Brandon. Sorry.
Brandon, yes. Those current data that's starting to come out that bupropion may be useful in treatment of stimulant use disorder. It's not currently FDA approved or recommended. It's not something that we are currently using in our clinical setting, but we're watching the data on that.
Great, thank you.
Yeah, no, thanks for the question. Yeah, so we use, and again, please do interrupt me if there's questions in the chat, and then we'll stop and have a conversation. We use Suboxone because it is a partial agonist. It treats the cravings and the withdrawal symptoms, but it does not put patients at the risk for overdose, like a full opioid, like OxyContin, the Norcos that we're using for pain. And what we know, when you're working in this field is that, buprenorphine has a street value now. It is being used in an unprescribed manner. And since it has a plateau effect, it doesn't give you the same with euphoria that a full opioid would, but it certainly can keep a person from going into withdrawals. And that's generally what our patients are seeking when they're seeking buprenorphine on the street. So treatment considerations, once again, methadone, buprenorphine, and naltrexone, and there's a whole lot of reason why you would choose one over the other. So I want to just move to youth. So the buprenorphine is approved for youth over the age of 16. And there are providers who have been using it under the age of 16. I do not. That would be a patient that I would refer to a pediatrician. And it has been demonstrated as effective along with behavioral therapies. So we are, like I said, part of the Youth Opioid Response Grant. We were recipients for the first round. We applied for the second round of funding. So our fingers are crossed that we will receive the funding. What we ended up doing with our funding was multi-pronged. We had significant interventions within the schools where we did screening and brief interventions for youth. So that's where a lot of our funding went into, and training within the school system. And then we had planned a opioid summit, but of course with COVID that all got shut down. But we did do it virtually. We had an expert come in and talk about youth and opioid use disorder. And we opened a clinic for youth. And so the clinic providers are myself. And then there's another PA, and then we have other behavioral health specialists standing by. So we got all that open. We got all that structurally open. We got all of the policies and procedures written to see youth, and but then we were very much impeded by the complete shutdown of the schools, because what made our system so good for addressing the needs of youth is Granite Wellness is across the street from the junior college, and it is across the street and like down a block from one of the county high schools, the large county high school, the high school in the county, and it is right down the street from the pediatricians, and it's right at a bus stop. So what we know is navigation is a significant issue, with youth, being able to get there, being able to access confidential services confidentially. So we felt like, number one, we have the providers. I used to run a school-based health clinic for adolescents on a alternative education campus. Been doing youth for a long time. So we had personnel. We have perfect site. We have the support. So Granite Wellness includes outpatient and residential care services. So we were very well situated to care for youth. And so what happened with COVID is all of that foot traffic kind of evaporated. Our connections with youth directly through the schools sort of evaporated. Everything got pulled back. We do provide telehealth services, but that has been really hard to connect to youth. So what I can tell you about our drop-in services right now is we are open Monday and Wednesday. I think it's officially 10 to 5, and we are waiting for youth to drop in. And that we are, now that our school up here has just opened up again, and they just reached out to us. We've met with the school several times. They just reached out to us last week. And so we're going to start the conversation. In one of our conversations with the school, it was just so clear how overwhelmed they feel. And they said, we feel like we're being expected to do everything. We're educators, but we have significant numbers of youth who have SUD, and we're expected to do the interventions, and we are desperate for help. So now that things are back opening, we're getting back into the schools and seeing how we can get the youth to migrate over to us so that we can actually see them. And then the other thing that we've done with our Youth Opioid Response Grant is on this slide. We've developed an app. This has been quite the project. So as the other person who has a Youth Opioid Response Grant knows, everything that you did was supposed to be youth driven. So we had youth focus groups. What do you need? What do you want? When would it work for you? This and that. And so that's how we came up with the drop-in clinic. You know, they can make appointments, but they can also just show up. And you know what? If they show up on a day other than Monday and Wednesday, we'll still see them. We designed an access point so that they don't have to go through our lobby. They can go around the back. They have their own entrance with, you know, there's a process for them to text. And I'll show you, we have a picture of our warm line text, our warm line posters. They can text, I'm here, let me in. We can let them in. So we've really been looking at designing everything we do based on our youth focus groups, including our app. So our app, the youth, what the youth told us is they don't want, obviously they don't want to just, you know, say no approach. They don't use those words, but they said, don't tell us what to do. Don't tell us not to use. Don't tell us what the drug does. And they said something really cute. It was, don't say anything like my plan or my planner or something like that. We're like, okay, got it. Oh, and so the focus groups were run by someone under, so the target age for the Youth Opioid Response Grant is 12 to 24. And our focus groups were run by a 23-year-old, and the lead app designer was a 23-year-old with support from a couple other app designers. So what we designed, it's called GW Connect, and it gives, the pictures here is it gives information on the medications, just straight up information from NIDA or SAMHSA, you know, and we had students, MPH students from USF helping put some of the information, the medical information together. And then it has a banner, how to use naloxone. It also has a functionality to give alerts. So we had a rash of fentanyl overdoses up here just recently. So we have the ability on this app to give an alert, fentanyl overdoses, here's what we're seeing, blah, 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 blah. There's a functionality on here for people to ask questions. So our clinicians will be responding to questions. And then there's a treatment locator finder. So if someone needs treatment, and there is a guided meditation, a couple of guided meditations that use images, the youth around here. So Granite Wellness is up in the Sierra Nevada foothills. I no longer live in San Diego, but the Sierra Nevada hills, the youth are very attached to the Yuba River. And so there are some guided meditations that they were designed by youth, they're narrated by youth, and they use the visual image of the Yuba River. So where we are with our app is it's in test flight, it's all constructed. Our fingers are right now crossed because everything has to be approved by the Apple Store, as you know, and Android. And it's only a little bit dicey because we're giving information on what drugs are, but we're super clear all throughout that this is about harm reduction, you know, safety, getting you treatment. So I'm going to stop there for a moment. Well, let me stop here. So these are our posters that were developed as part of Youth Opioid Response to one, you know, getting information out there. And the other thing that we did was develop a warm line. And this is a call, they can call and they can text, and they will immediately get one of us in the back office. It's managed by our medical assistants, but it's trying to avoid having youth have to go through the rigors of, you know, front office that sometimes can get busy. So I am going to take a breath and stop there. And I just want to open it up to thoughts that people have on. So what I've laid out is our game plan for connecting youth to services, and our struggles with the fact that we have, you know, it's kind of like the Field of Dreams things, build it and they will come. Well, we have built it. But we still are not getting youth. And again, when I say still, we're so early in this, given COVID, that, you know, people are now just leaving their homes, but we're still struggling with getting youth in the door. So I'm going to open it up to people with we'd like to hear what they are doing for youth in terms of treatment and harm reduction for SUD, particularly OUD.
Hi, this is Anna. Like I mentioned, we were part of the YOR. We have struggled significantly with the closures of the schools. So what we did is that we transitioned all the face-to-face on-site visits, because a lot of our services were provided at the schools. With the closures of the schools, we transitioned to telehealth services. However, that has been a challenge to conducting the groups or individual sessions. We have been able to do the follow-up telephone calls, but it's been really difficult, really challenging to get the commitment of youth to continue with group sessions for different reasons. Their household is not equipped for confidentiality, mom walks in the room, etc. But also we've been doing a lot of outreach to with the school districts, with the juvenile justice system, and even then we haven't seen referrals come in. So, which is really, really concerning. Our numbers, our cases have dropped significantly. So any ideas, you know, are welcome. And I would definitely like to reach out to you as well after this symposium.
Yeah, I'm all about working together. Let's figure this out together, because I think, you know, we are definitely having the same struggle. When you say outreach, so, you know, we're sitting there waiting for the youth to come in. We're taking care of, I take care of patients who, so my kids are adults now. One of the patients in our, that I take care of, my oldest son's age, so 30-ish. I mean, just heartbreaking stories I hear in group. Also, we used to have face-to-face group. His girlfriend was also a longtime partner in the group. How many times she Narcaned him? Like 5 times. This is a young man who, I've watched grow up, play basketball with my son. And so we're seeing them obviously, like everyone else, in that young adult age group with significant overdoses. And then we go out to the skate park, not me particularly, but the people who work in my office who have better connections over there, go to the skate park, they take a couple pizzas and they sit and talk, and they let them know that, we can get you on buprenorphine, we can help you, we can talk about this. So it's not like they're not out there. We know they are, and they're interested, but we still just can't get them in. Other thoughts on engaging youth and actually getting them to services? You win the prize if you solve this puzzle.
And I just wanted to, I'm not sure if anybody else is struggling with outreach. So I just give you an example of what we recently came across. In November, I reached out, we partnered up with mental health. We provided a presentation. This all started, the whole coordination started in November. One of the school districts reached out to us that parents were really concerned for their children. The pandemic has caused a lot of anxiety, depression, they're concerned for substance use. So we went ahead and partnered up. We collaborated with one of our local school districts. The whole collaboration began in November. There was social media. They sent out letters. There were retention calls. In December, we confirmed the date. We scheduled it for January 26th. And it was really, really hopeful. And only about 15, 17 parents showed up to the Zoom presentation. And we continue to do that. And I haven't lost hope. We continue to reach out. We had one this week with our special ed educators, and we have another one next month. So we've been continue to promote and advocate for services, letting them know that we're still providing the services, because I believe there's also that misconception that services are no longer available. Of course, through, because of safety measures, we have transitioned to the telehealth Zoom platform, but we still haven't been, very successful with this population specifically.
Yep. I will say that our recovery and wellness series, it was November we did naloxone, December we did harm reduction, November we did OUD treatment and naloxone, December we did harm reduction. Those seem to be pretty well attended, not by youth, but at least by adults who we hope have access to youth in the home and can continue to forward the information. So others on the call that, maybe you aren't working in a youth clinic, maybe you didn't have a youth opioid response grant, but you were youth. So any thoughts on how these programs can we know they're there? So I was reflecting on, because I teach also in San Francisco, it seems like they are accessing more the youth with opioid use disorder because they were asking for our students, particularly our clinical psychology students. We need more students to help us. I don't know. We know, so I'm in a rural community. We know they're here because we're seeing them overdose as young adults. And we go to the skate park and they say that, they're using heroin. And the other reason we know, I'll tell you, I used to think that I had a handle on SUD in adolescence a little bit, not an expert, but a handle on it because I worked with youth for so long in an alternative education site. I was not prepared. Absolutely not prepared for what I heard when I transitioned into an opioid use disorder treatment specifically. I was not prepared to hear that. I was smoking weed with my family when I was in middle school. I was not prepared for. I was using IV heroin with my parents while I was in middle school. And I have heard it several times. So we know they're out there. Any suggestions from just your own personal opinion on how better connect?
I wonder if there's a creative use of Instagram and videos to have little tidbits that can make the social media realm that could refer back to the resources you have available, just because of the world in which adolescents live in is so largely TikTok and Instagram oriented. Mm-hmm. I wonder if there's a creative avenue of using those channels.
Mm-hmm. Yeah, thank you. We do have, and we have a young adult, at least, not under 25, but a young adult managing our Instagram account. Has anyone had any success with that? I don't think we have a TikTok, but I'm pretty sure we have Instagram.
It would be interesting to have a hashtag that we can develop collaboratively with some partnerships if we make some connections that really start to overlap and have its own kind of housing, I guess, so to speak. Because I found that the video, just anecdotally, IGTV videos just get a lot of views. And I wonder.
Mm-hmm. Yep, thank you. What are some thoughts on that? How to do it, how to connect, how to get them, how to engage them. Okay, Dawn.
And I was just kind of thinking back to what you were saying about, well, I was a kid once too, and how would I have wanted to have been approached about those types of things. And I immediately thought about, like the mistrust against adults, and then somebody's just trying to come and rescue me and save me. And so I thought of like maybe someone close to their own age in these like marketing, like the Instagram, like these, like if you were to do like a PSA about like when that individual that you mentioned, the example of like, oh, I was using IV drugs with my parents. in 8th grade. I imagined like a younger, maybe a 17-year-old or somebody like me who looks super young. And then they can kind of identify and relate a little bit better rather than us coming in as adults and going, hey, we have all of these programs, we have this access, and we have all of these things for you that you can utilize as tools and to help. And, you know, I mean, just looking back, wouldn't have wanted to be bothered with that anyways, because the peer circle is, you know, just everybody your age, your friends, and somebody who looks like you, talks like you.
Yep.
Yeah, you would need gatekeepers. Yeah, people like that.
Explain, speak more about what you mean by gatekeepers.
Yeah, individuals like she's saying, people that have a connection to that world. For instance, like one of my professors before, I remember he did outreach with youth for heroin addiction, and this was at Loma Linda University. It's an SDA university, for those of you that know that university. And he's SDA, and the way he talks and teaches in class is not the way he is when he's with his youth over there. So he actually is connected with other youth that hang out with them, know them, are in recovery, and then he is introduced to them through this individual. And then even when he's talking with them, he actually speaks more of their language. You know, he'll even use, you know, he'll curse. You know, he doesn't go out of his way to do it, but he's more relaxed, because if he was the same way, they wouldn't want anything to do with him. And he has a very good relationship with them, but he had to have that connection of somebody that knew them to bring him into the fold. You know, it's like I'm half Mexican, but I wasn't raised in that culture. I could not go into a Hispanic culture and deal with them. I would have to have somebody that they trust, maybe a community leader or something like that can bring them in. So, but I think it's going off what Ton's saying.
Yep. Yeah, that sounds like a great idea. And for those who didn't pick up on that, SDA, Seventh-day Adventist, Loma Linda, the best cafeteria of any university I've ever eaten at. Because Seventh-day Adventists are usually vegetarians, right? So the food was really good.
One thought from the chat from Argelia. What about exploring strategies that the Truth Campaign has created? Their staging is very relatable to youth and how they look, who the influencers, their surroundings are, etc., and how school reps are being involved.
Okay, great. Can you explain that more? Speak more about the Truth Campaign?
Sure. It was, you know, to piggyback a little bit on Dr. Bitta, how I'm thinking of my niece who's 15 and that age group who also think TikTok is not cool anymore, who are not, you know, that was 2 years ago.
TikTok? Oh my.
And so, you know, I feel like, so content that feels truthful, right? Content that exposes, like, you know, you were saying, Alexa, how like it's being used with parents, right? So maybe like media content that explores those issues and surroundings, like that feel really genuine versus, you know, a flyer that everything's going to be okay, right?
Right.
So I think it would be, you know, attracting at least the eye to see that we're willing to speak the truth, right? And then, you know, someone just mentioned it, you know, utilizing like community reps or school employees that already have that trust and that relationship, right? So exploring locally, how can we utilize those folks that don't necessarily are certified or are, you know, nurses or doctors, but can reach to youth, right? A lot of the times our folks at schools don't have the information, right? I think it's, you know, free and confidential. Your flyer says that's great because, you know, we're often asked, do they already have to have Medi-Cal? Do they have to have proof of that? How, like, there's already layers of, you know, misinformation sometimes.
Excellent. I love that line, as opposed to everything will be okay. In part, that is like what the our youth focus groups were telling us. Don't just tell us, don't just sugarcoat us, just tell us what the drug is, tell us what the drug will do. And then of course we try to also tell them what naloxone will do and how to use it and how to get to us. The use of gatekeepers, as you mentioned, the use of peers. Certainly I know our youth opioid response grant had peer advocates in it. Again, it all got crazy because just for background for people who weren't on that grant, we received these grants like in July. It was a year grant. You ramp up and then pretty much everything closed in March. And so it almost doesn't count, that grant, in terms of did it work, because COVID was such an influence, but we did have peer advocates. I'm particularly interested in the near peer approach, because at one point in time, when we still had face-to-face groups, we had really robust face-to-face MAT, medication assisted treatment groups, which were just phenomenal to participate in. And if you have the opportunity or find the opportunity, go to a treatment center, ask if you've never done it, ask if there's a way for you to be able to participate in a group. It involves confidentiality, so it'll be up to the system. If that's a possibility, or go to an NA or AA group if you can, and get into an SUD treatment and listen to how these people talk. That is the most inspiring thing I have done. So I've gone into the groups, like I was telling you, this the friend of my son's who's incredibly cool, long dreads, just fabulous human being, would have died 5 times without Narcan. And I said, here's the deal. We know they're there. They talk to us when we go to the skate park, but we can't get them from there to here. Would you be willing to? And they kind of nodded. Yeah, we know they're there too. People who are using that are under 25. Yep, we know they're there. You don't magically OD at 25. And so I said, would you be willing to maybe reach out to a youth and bring them into a group? Just say there's no commitment necessary here. Just come join the group and sit and listen today. And they were what I would call the near peers, the people over 25 with being in treatment for SUD, were interested, but then it got derailed because then all of our face-to-face groups closed. And I don't think I could get the same effect with find a youth, set up a Zoom, meet us by Zoom kind of thing. So we might try to restart that. Any other thoughts on how to engage youth and actually get them in the door?
Michael has a question. What curriculum are you using for your groups?
So our MAT group, specifically, we don't use an identified curriculum. We don't use one of our curriculum, standardized curriculums that we buy. The person who runs our adolescent SUD groups in Auburn uses a variety of those the curriculum. At Grass Valley Granite Wellness, where I work, we did an adapted version of a curriculum that Kaiser was using. So yeah, we made our own from a variety of resources. But if you want to write to me, shoot me an email. I can shoot you a list of the different ones that are used throughout the system. Any other thoughts on how to engage youth? Okay, I'm going to move through I have a ton of information, and we'll just stop where we feel like stopping. Just back to, what we know is that our overdose deaths that we're seeing are from fentanyl. And it's not just some people who are thinking they're going to use an opioid. It's not just fentanyl in heroin. It is fentanyl in benzodiazepines. We actually had a youth die in our treatment facility. He came in for a benzodiazepine use disorder, which, boy, that stuff scary as well, right? The overdose potential on its own, plus being laced with fentanyl, and then the risk of during withdrawal. But he was in our recovery center for benzodiazepine use disorder, smuggled in some what he thought was benzodiazepines that was actually laced with fentanyl. And the description that's really stuck with me about what's the deal with fentanyl is, the drug dealers use fentanyl to potentiate the effect of the drug because they want the person to come back and buy from them. They want, they're trying to give them that ultimate high, right? They're not trying to kill off their market. That would not make any business sense. It's a business model, but certainly there's no control over that. So what we're talking about today and what we've been talking about is really harm reduction approaches. And that's really what we're doing with our GW, Granite Wellness Connect app, is taking a harm reduction approach, giving information. Again, this is what we also believe in as harm reductionists, but also what the youth told us, just tell us, we just want information. We just want information. And then we tried to provide also a little skill building on mindfulness, et cetera. So the harm reduction approach is to, reduce the negative outcomes by providing safer techniques, managed use, and certainly promoting abstinence. And really what we're doing is we're taking the American Society of Addiction Medicine's framework for understanding addiction. It's a chronic medical disease that involves complex interactions between brain, genetics, environment, and individual experiences. And really looking at each of our clients from a biopsychosocial understanding of health and trying to develop all of our implementations at each level. The biology, we can take care, we can knock out that opioid withdrawal and take care of opioid cravings within 24 hours with buprenorphine. And then certainly the psychology, using our evidence-based behavioral health approaches, and then, working in a wraparound method, trying to improve the social structure of their lives. So really in a harm reduction approach, we're looking at, what is the risk? What is the real risk of the activity? In this case, the drug that they're taking. What's the mindset that they have when they're taking that drug? Are they particularly upset? Do they have a fatalistic? This is what, and you all know, and I've heard today about the escalating overdose deaths during COVID. Well, is it related to this mindset of just being fatalistic? And then what is the setting? Are they in a setting that is safe to be using an inebriating substance? And what we look at with adolescents, particularly, or everybody, is there is a continuum of drug use. Some people don't use, youth experiment, people use socially, people use regularly, people use habitually, and then there can become this chaotic, persistent use. And in one of the presentations I heard earlier, they were reaffirming that let's not pretend people are going to stop using substances. That hasn't happened throughout the history of man. So let's ground ourselves, and people are going to be on this continuum somewhere, and we need to meet them where they are on this continuum. And certainly all of our principles of harm reduction, of dignity for everyone, being very patient, participant centered. The patient-centered care in the nursing world means the patient is a full partner in the development of the treatment. So same thing with participant involvement. We don't design the recovery plan. The participant designs whether harm reduction or recovery plan that best suits them. And then acknowledging that they have full autonomy, addressing the psychosocial factors, and being very realistic about the expectations within society. Really looking at the management of SUD from a harm reduction approach of social justice. So one of the big things that we need to work on is stigma, addressing stigma. This conference has been in large part addressing stigma, and how our use of language perpetuates stigma. So one of the things that we have on our Adopt site is a monograph on stigmatizing language. We did a narrative review on stigmatizing language in SUD, and what we found in this review was that it reinforces implicit bias, and it does affect quality of care. So if you're interested in more of that work, you can go to our Adopt website. If you go into resources, you'll find the monograph on what we found from the literature to be considered stigmatizing language. Now, I think it's very interesting. So certainly we talk about SUD, right? SUD. Well, my clients still talk about addiction and call themselves addicts. So I kind of navigate in that space. As I work very hard to try to not use stigmatizing language, and I go with wherever the client goes. So we only have a few more minutes, and I just want to go quickly through some of these things. We need to look at cultural barriers to care. We need to look at structural barriers to care. Making sure we're developing systems where people can get care, and some of the classic harm reduction services. This material is from the Harm Reduction Coalition, and you can go on and take a look at it. But and that's more for clinicians, making sure people have naloxone. On our app, our youth app, there, that we have a way for them to learn how to use naloxone. So places for you to go or your clients to go would be the National Harm Reduction Coalition. Tell you how to find naloxone, tell you how to find syringes. California Opioid Safety Network will provide resources, and that's supported by the California Healthcare Foundation. This is my little site. This is where I work. I park over here. It's a fabulous place to work, and we do great work. And we go out into the community, and we bring Narcan to the community. This is us at the skate park. There's a skateboard. Got fentanyl test strips, Narcan, and again, and education on first aid, trying to get them to see Granite Wellness as a safe place to come. Be aware in terms of your policy work that there is another Senate bill out to support the creation of a safe injection site. This is the model site that was in San Francisco. I got to tour that. That was extremely cool. It was right in downtown San Francisco. And so be on the lookout for this bill. If this is something that you support, please do contact your own elected representatives, both Senate and Assembly. It would start with providing a overdose prevention program, including a hygienic place supervised for people to consume pre-obtained drugs, provide sterile consumption supplies, and provide access or referrals to substance use disorder treatment, starting in San Francisco, LA, and Oakland. And if it can get off the ground there, maybe it can get off the ground other places. So it is 2:43. I really appreciate the hour that you have spent with me. I would love to continue this conversation. You have my contact information. If I could ever be of any help to you, just reach out. And any other last thoughts? Okay. Well, thank you, everybody. I think we have a final panelist wrap up, and please do reach out to me.
Thank you so much, Ms. Curtis.
Yes.
Yeah, it's fun.
Thank you so much, Dr. Curtis. Yeah.
Fun being here with you. So please don't hesitate.
Thank you, both of you.
Okay, bye-bye.